حنبدأ إن شاء الله. بسم الله والصلاة والسلام على رسول الله. طيب يعني I was asked to present all about joint and bone infection, which I think is extremely difficult to summarize it in 1 hour. So first of all, I have no disclosure. Before that, really, I would like to thank the organizing committee for their invitation and to present this topic. This is some of the objectives which I have been asked to present it. It's like about shortening of antibiotics, retaining of prostheses, and the antibiotic prolongation, and what about the MDRs? So, so it was like, I don't know where I have to start. Shall I start with septic arthritis, prosthetic joint infection, spine infection? But then I decided eventually to exclude diabetic foot because I think this is deserve one more presentation. So as you see, we classify the infection into like 2 parts. One is the implant retained infection and non-implant retained infection. So probably most of our talk about the retained implant, either spine instrumentation or fracture or prosthesis-related infection. And if there is a time, then we'll go to the non-implant related infection. So vertebral osteomyelitis, chronic osteomyelitis, and septic arthritis. So as I think, as you know, nowadays we are seeing more of prosthesis implantation and infection. So 1 million total hip arthroplasty and total knee annually in this is USA. And the knee, by the way, is more risk of infection than the hip. Do you know why? There is no really clear explanation, but some of the thought, it's like movement of the knee is more than the hip, or probably less coverage with the soft tissue on the knee. So still the knee in the overall or all over the world have more higher risk of infection. So some people, they treat the knee more aggressively than the hip and even more prolonged. The excellent thing, what I think this is opportunity also for research, the data from Saudi, this is publication from National Gallery of the prosthetic joint infection around 1.2 rate. But again, you have to know how they define the prosthetic rate infection and what's their criteria. So this is again data from USA. The number of prosthesis infection is increasing, but again, increasing the prosthesis itself. So overall, the rate is going down, but the total number of infection is increased. And for those who are interested about to know what's the infection or the common infection, it's really gram-positive. Staph aureus and coagulase negative. This is the most common, which around 82%, followed by gram-negative in 11%, and QT bacterium species. And this is the new name for it. I think the previous name was Propionibacterium acne. So, and by the way, in shoulder arthroplasty, and some data showed 44% of shoulder arthroplasty are caused by Cutibacterium species. So this is our nightmares. This is the biofilm. So if you see the biofilm is not only in the prosthesis, the biofilm in the cardiac devices, biofilm in the PEC line, there is a biofilm with the prosthesis. Everywhere you will see the prosthesis. So why the biofilm is really important for all of us. So the prosthesis is foreign body. There is no vascularity, and the host. How you will deliver to these prostheses. So there is no vascularity, foreign body, the mechanism and action, or how it would, the antibiotic work in such media is extremely difficult. And minimum inoculation, minimum antibiotic can cause an infection in prosthesis related infection. And this is really one of the interesting articles. 44 patients with prosthesis, they developed Staph aureus bacteremia. Imagine 34% they develop prosthesis related infection. So this is why if you are treating Staph aureus bacteremia in patients with prosthesis, they are really at higher risk for prosthetic related infection. 1/3 of Staph aureus bacteremia, they develop prosthesis related infection. Sorry. And some data showed that 3 weeks of infection in prosthesis associated with young biofilm. Young biofilm, this means probably the chance of eradication of infection is higher. So this is from the literature. This is a prosthesis was explanted, and it was cultured. See the growth over the prosthesis. This is indicating the presence of biofilms. So this is why we are classifying the prosthesis infection into early less than 3 weeks, or more than 1 month, and late presentation. So if you have really less than 3 weeks, the early post-operative, so this is the most organisms are coming from the perioperatively. So you will see patient presented with fever, effusion, wound, dehiscence, and the common organism is the Staph aureus, Enterococcus, and Streptococci. However, if the infection is more than 1 month of the surgery, or if the implant, you will see like some sort of delayed infection, persistent pain, loosening, and you see it like frequently after how many months of surgery, it turned to be a coagulase negative. And anytime this is, seeding with bacteremias, and as we said in Staph aureus bacteremia, for example. So again, if you are treating prosthesis-related infection, you have to have a strong collaboration with your team from ID point of view, orthopedic, your clinical pharmacist, plastic surgeon, and to decide the best approach for patient. This is a common that how we can, the clinical picture or feature of prosthesis-related infection, you will see erythema, edema, and sometimes loosening. If you see a sinuses, this is like as a pathognomonic feature of prosthesis-related infection. Again, this is some criteria of how to define it. The consensus European and American societies is if there is a sinus, this is like an indicative of prosthesis-related infection. If there is a two positive cultures, then this is one of the indication. Synovial fluid leukocyte more than 3,000. Synovial fluid neutrophils more than 80%. Histopathological diagnosis, and this is it goes to how to diagnose it. This is from the IDSA guidelines 2013. Diagnostic arthrocentesis. I don't know if you are going to convince your colleagues in orthopedic, or diagnostic arthrocentesis should be performed in all patients with suspected acute prosthesis-related infection, unless diagnosis is evident. Sometimes you will see the pus coming out from the scar of the wound. So this, you don't have to do like further evaluation. This is prosthesis-related infection by all, or if there is a sinus. But sometimes you have like some sort of subacute, or there is like an effusion or increased inflammatory markers. This makes you like worried about, is this really prosthesis? And really difficult to diagnose it. And if patient went to the surgery, minimum should be three cultures, at least 3 culture taken from the site of the surgery, and optimally 5 to 6 intraoperative culture should be submitted for cultures. So type of infection and surgical management, it depends. Are you treating acute, or are you treating chronic infection? What type of surgery? and local antibiotics, and the implant-related infection. There is like many surgical approaches, either implant removal in 1 step and 2 step. So we'll speak in next few slides about it, and either debridement and implantation retention. So this is, as you are a clinician on ID, you have to discuss the options or with your orthopedic team and see what is your patient is going for. So this is the radiological manifestation. Some radiology is really not much really helpful in prosthesis-related infection. X-ray is really non-sensitive. MRI, there is an MRI. The sensitivity is around 65 to 94% with specificity, but it associated with multiple artifacts in prosthesis. There is some like sequences called STAIR or STIR. It might diminish the artifact with the prosthesis, and there is some trend, or there is some recommendation that probably is better than the other modalities. Again, nuclear medicine with excellent sensitivity and specificity, but again, sometimes it's confusing. White piece scan, it showed really high sensitivity and specificity, but again, I don't know if this is really readily available in all hospitals. And PET scan is highly sensitive, but specificity is like wide range, and probably no much like experiences about using of PET CT. So sometimes the imaging this is the IDSA recommendation. If you would like to do the images, however, should not be routinely used to diagnose prosthesis-related infection. So sometimes is really confusing or is not really much helpful in some cases. So this is the modalities of surgeries. So debridement, antibiotic, and implant. So they will open the surgery, do debridement and cleaning and retention of the implant, and they will close, and then patient will receive antibiotics. And this is successful rate is ranging. This is the data from Europe is higher rate of cure than the North American. Probably this is more than in Europe, with really excellent response. However, if the criteria of early infection less than 3 weeks is not there, so probably you will go down to 14 to 68%. So the time management and using of debridement and retention of prosthesis is really important. 1-stage revision, more in Europe again, more than 3 weeks of symptoms, but there is no difficult organism and satisfactory condition of the soft tissue, success rate around 85% to 100%. 2 stages. What we are doing really in our hospital, we are doing more of 2 stages. And this is more of like North American approach used in compromised soft tissue. And the success rate is really high. So which one is better, 1 stage or 2 stages? There is an ongoing trial in I think in the United States, and they start recruitment 2016 and still in progress. I don't know how much of the number they need to see if there is 1 stage is non-inferior to 2 stages surgery. For this is some of like an example. This is the 1 stage. They took the prosthesis, they put cement impregnated with antibiotic, usually gentamicin or vancomycin. I'm not really sure about the data about that, but all from observation and retrospective data. This is the polyethylene. And then after antibiotic, patient went to 2 stages and the prosthesis were inserted. So this is like an example or how the surgery done. This is debridement and retention of prosthesis. They will remove the exchange insert, cleaning, debridement, and then antibiotics. And the 1 stage, they will exchange the prosthesis, the whole prosthesis, debridement, and they put the new prosthesis at the same surgery. 2 stages, they will remove the prosthesis, put spacer, antibiotics, and then later they will put the second prosthesis. So as we said, if the prosthesis is less than 3 weeks from the insertion or symptoms less than 4 weeks, and well-fixed prosthesis and no sinus tract and no difficult to treat organism, so the debridement and retention of prosthesis sometimes can be done with excellent review or excellent data. And if you see the most of the published literature recently, it showed like more than or 90% of success rate. So do we have to give IV or oral antibiotics? Options, duration, do we have to do a 6 or 12 weeks? Or do we have to do a longer? This is, we'll try to answer it in the next slide. So this is the IDSA guidelines, 2 to 6 weeks of pathogen-specific intravenous. But this is 2013. This is like, 11 سنة. IV. And this is 2013. Do we need really longer IV treatment? But there is a more really trials of antibiotic, including endocarditis and prosthesis. So if you go really to the history of intravenous antibiotic, this is 2004, which was like a state-of-art review was in the New England Journal of Medicine. They recommend to give an IV treatment 2 to 6 weeks. And this was based on a rule of rifampin for treatment of orthopedic. This is in JAMA, I guess, 1998. And the rationale about it, about the IV treatment was this initial 2 weeks course with standard intravenous treatment was chosen to minimize the risk of emerge of ciprofloxacin resistant. So again, there is no really clear rationale why we have to use an IV. And again, this was in 1970, this is like 60 years ago, when they said, no, osteomyelitis is rarely controlled without a combination of careful, complete surgical debridement and prolonged 4 to 6 weeks. So there is no really convincing or really an excellent data to convince people to give an IV treatment for a longer period. So this is one of the major trials that is really make a difference in our practice, which is OVIVA trial, oral versus intravenous antibiotic for joint infection. It was open-label randomized controlled trials in UK, 26 centers. There is more than 1,000 participants, and 60% was metalware-related infection assigned to receive either IV or oral antibiotic to complete the first 6 weeks of therapy. And the randomization was within 7 days. So they give 7 days of IV antibiotic. So for the IV, they give glycopeptide or cephalosporins. And for oral antibiotic, they are using quinolones. Oral antibiotics therapy was non-inferior. So the oral antibiotic was non-inferior to the intravenous therapy when used during the first 6 weeks. So based on this trial, I think we have really a convincing evidence that we can switch our patient early to oral treatment. So it was really non-significant over all the patient. So this is the organism what they discovered in their surgery is mainly gram-positive, Staph aureus, coagulase negative, Streptococcus, and rarely or Pseudomonas around 5%. So what we have to use in Staph aureus infection, usually we use either Nafcillin, or this is the IDSA guideline, either cloxacillin or cefazolin. But if there is an MRSA or coagulase negative methicillin resistant, we use vancomycin. And this is the oral options. The Cipro and levofloxacin was top of the options with really much stronger evidence than the others. Potrimazole, doxycycline with lower data and cephalosporins. So I was really curious about what about the new data? Is it still using quinolones for probably gram-positive infection? Here in the antibiotic therapy, this is another trial, 6 weeks. The quinolones or fluoroquinolones was around in 70% of patients. And this is from 2011, 2015. And the new trial I mentioned, quinolones around 40 to 45%. So most of the trial, they use quinolones as a drug of choice, even in the gram-positive organs. So do we have to use rifampin routinely in those infections? So rifampin should not be used, never been administered alone. So this is all we know, that rifampin can get resistant easily, and staphylococci rapidly develop resistant. And used in this trial, they use it in both coagulase negative and Staph aureus and coagulase negative, but to the least extent, coagulase negative. And one of the major trial of using rifampin, which was, I think, is in 1988 or 1999, the role of rifampin for treatment of orthopedic implant-related infection. This is a randomized controlled trials, which showed a significant effect, a significant improvement when they used rifampin for prosthesis-related infection. However, there is, but the number of patients here is around 33 patients. 33 patients, and it was 1998. So this is really rifampin should be used. This is another from Norway randomized control trials, a little bit larger number of patients, 99 patients. As we said, they used rifampin in debridement with in debridement and retention of prosthesis. So there is a prosthesis. So it is not like in 2 stages therapy that when they remove the prosthesis, they don't usually use the rifampin. They usually use rifampin if they did debridement and retention of the implant. 99 patients, and this is really was disappointing. So this trial has not proven statistically significant advantaging by adding rifampin to standard antibiotic. This is makes like very like controversies among the treating physician. Do we have really to use rifampin or not to use really rifampin? So again, in systematic review, they reviewed almost all data about rifampin, and the data indicate rifampin may only prevent a small fraction of treated failure. So when even I reviewed the literature, I was really confused. So is the rifampin is a drug of choice? Should be rifampin, or we should argue, or we should ask rifampin should be a part of treatment of prosthesis-related infection? You know, this is you know, the guidelines what was published in JAMA last year about using of rifampin. I was like curious what they are saying. What they said here, really, I like it. Overall, the data mixed and remain uncertain. So, and again, there is a review was published in a review was published last year in New England Journal of Medicine. I like what they said as well. Rifampin is often used along with other active antibiotic agent in patients with debridement and retention of prosthesis, although there is a conflicting evidence supporting this practice. So again, there is a conflicting evidence about use of rifampin in prosthetic joint infection with the Staphylococcus infection. However, I think it's still have been used, and still the advocate for rifampin, they have like a much argument about the Norway study, which they thought about probably is more of chronic infection they used in this study, and probably the selection of patients is not really good, and probably smaller number of patients. So we don't know. Let's see. There is a coming trial trying to help us. But again, rifampin is not really easy journey. Rifampin associated with significant side effects, including hepatitis, GI symptoms, drug-drug interaction, and you have really to explain to your patient the side effect, or is not the side effect. Sometimes it's like the changing of urine while using rifampin. Otherwise, the patient will throw the medication and will say, okay, you make more a problem for me rather than you are helping me. So again, if we are doing the first stage, antibiotic with the antibiofilm agent like rifampin, if we use one stage revision, antibiotic with antibiofilm agent probably is recommended. And if we use 2 stages of therapy and the prosthesis was removed. So 2 stages simply in simple language. يمكن الناس اللي ما بيشوفوا الحالات زي كثير ياخذ البروستيسيس ويركبوا سمنت. المريض ياخذ antibiotic for 6 weeks. بعدين يركب البروستيسيس مرة ثانية. But during removal of prosthesis, probably antibiotic with no antibiofilm agent is needed. However, some they recommend it in some Staph aureus infection. The phases of treatment of prosthesis-related infection can be defined as planchotic phase, which is a recent, there is an infection. See, there is a pus, surgery, high bacterial load, risk of emergence of resistance. Probably the preferred one is beta-lactam. And as in the OVIVA trial, they used IV antibiotics. So once the patient is improved, drain removed, the scar is like, there is no like improvement, then at that time, you can consider your oral antibiotic biofilm like rifampin if you'd like to use it, but don't use it upfront. So I think there is no really cutoff when you start rifampin, but probably when you have really debridement, removing the drain, dry wound, this time you can start rifampin. As we said, because of resistant and early resistant. So for how long? 6 weeks or 12 weeks, or do we have to give it longer? Again, the IDSA around 3 months for the knee and 6 months for or the opposite, 3 for hip and 6 for knee, because they thought his knee is more prone to have infection. And what about for 1 stages again? And if we remove the prosthesis to give a 6 weeks, 4 to 6 weeks of pathogen-specific therapy. However, what about the short duration, about 6 weeks therapy? So this trial, really we have really major trials in the field of prosthetic joint infection. This is the 6 versus 12 weeks for prosthetic joint infection. It's really huge study called the TIVO trial, open label, comparing 6 versus 12, and the outcome was a persistent infection. They follow the patient for two years post the surgery, and the therapy for 6 weeks was not shown to be non-inferior. This was really disappointing for those who thought the 6 weeks. 6 weeks is really enough for treatment of prosthesis. However, if you go really to the literature or to the data, this was, most of the patient was debridement and retention of prosthesis, and this was really clearly in debridement and the retention of prosthesis that is 6 weeks shown not to be non-inferior. So I think by this trial, if you have really debridement and retention of prosthesis with the criteria of 3 weeks of surgery, I think it's minimum 12 weeks should be used rather than 6 weeks. However, and for 1 or 2 stages, is still debatable. It does not show clear failure as in debridement and retention of prosthesis. So I think it's still back and forth, and still there is like a debate about that. But I think 1 stage therapy probably will give longer, 12 weeks. But I think in 2 stages therapy, still there is a lot of debate about it. So do we have really to give a holiday therapy? I was not really able to review the literature, but yeah, still this is the old recommendation. You have to give 2 weeks prior to the collection of synovial fluid. So they give like 6 or 8 weeks of therapy, and they give a holiday for 2 weeks for organism to regrow or to help the organism to regrow. And then some people, they took an aspiration or taken them to the surgeon and take intraoperative cultures. In literature, they're saying they find like 5%, 5 to 10%, but in reality and practice, or in reality, or in recent conferences, there is most of patients they turn to be negative. So still there is a question: do we have to give a 2 weeks holiday therapy or no? Still, I think is really, really debatable issue. So still there is a hope. So this is a patient that I saw in our hospital. He's a 30-year-old RTA 2019, acetabulum fracture, post-fixation with multiple screws on 16 of April 2019. One get infected in 2009. And CARPA-R, I think this is retro. I think I saw the CARPA-R in 2023. So probably I mixed up with the result. So underwent debridement and retention of prosthesis. But again, this patient is not really filling for the criteria of easy to treat or not difficult to treat organism. And started tigecycline and meropenem for several weeks. So this is the surgery. We are not a surgeon, but see how difficult properly the prosthesis was inserted. And this is really the sensitivity. It was only sensitive to tigecycline. So let's see if really debridement and retention of prosthesis can help here. If you see, the surgery was on 30th of April, but he underwent surgery like 2 weeks. So yeah, so he did the surgery here on 16th, and the first debridement, this is 2009, 2 weeks. So is this really fresh surgery? So this is one of the biggest ECMID trial treating of multi-drug resistant organism in prosthesis-related infection. E. coli, Pseudomonas 25%, pneumonia 24%, and Enterobacter. Debridement and retention of prosthesis was 67 patients. It's like 50%, colistin versus non-colistin, and it showed really higher failure rate in debridement and retention of prosthesis. See here, the debridement, the success rate around 40%, rather than non-debridement. So non-debridement, which is 1 stage or 2 stages, around 80%. And if you go here, if you are really trying to find if this is really early infection, and probably the earlier surgery can be really helpful. So if there is an early prosthetic joint infection, again, 45%. So it's really, there is no much, convincing evidence about that. So our patient readmitted multiple times, underwent multiple surgeries, so far 7 surgeries, debridement, and long antibiotics. Prosthesis removal is recommended by ID team many times, but again, there is back and forth discussion with the patient. Patient came again now with the sinus tract. So prosthesis should be removed. And how it will be removed, really, I don't know. It's probably a major surgery, and there is a risk of fracture of the pelvic bone. So rule of suppressive therapy is really a very limited rule. If not candidate for surgery, you can attempt the suppressive therapy, unlikely to cure the infection, probably lifelong, and with significant really side effects, So if you go back to our patient, he's around 34, and there is no even single oral antibiotics. So to summarize the prosthesis-related infection, so the timing of prosthesis-related infection is really helpful and important in managing patient. Really need a strong collaboration with your team. Rifampin used in prosthesis-related infection is conflicting data, remain uncertain, but I think it's still used in the practice, waiting to have more trials to help us the answer. Data is very promising for oral therapy, and 12 weeks is better than 6 weeks, especially in debridement and retention of prosthesis. And probably one stage revision, 2 stages still really debatable. So this is the first part. I think is really lengthy lecture about all joint and bone infection. So we'll try to summarize and so well, now I will go to the second part of this of the presentation. We'll try to make it like shorter. This is non-implant related infection, either chronic infection, septic arthritis. So this is a patient from the patient. Really, I forgot the details of this patient, but I collect the data retrospectively. So retrospectively data. So probably there is a bias on recall bias. So سامحوني لو نسينا تفاصيل. 83-year-old elderly patient, known case of type 2 diabetes, hemoglobin A1C7, hearing impairments. He said, I received injectable medication probably a longer time ago. Not sure about it. Presented to ER with right knee pain for 1 to 2 days duration. Difficult historian, but I went back to the literature. Patient was in the primary health clinic 5 days ago. So probably he was walking at that time when he went to the primary health care. So progressive swelling, and now he's not able to stand. During the assessment, patient was febrile, right knee exam, warm, swollen, limited range of motion, and the patient admitted as a septic arthritis. So WBCs is normal, hemoglobin and platelet were normal liver function test. Creatinine clearance was 37 ml, CRB 111, knee X-ray, no fracture, but effusion. Blood culture is ordered. So this is the synovial fluid. The WBCs is 35,000. 90% is neutrophils, and crystals were negative. So this is patient admitted as a synovial, as a septic arthritis. So this is some risk factor about age, diabetes, rheumatoid arthritis. They are more higher risk for Staphylococcus infection, joint surgeries, hip prosthesis, and IV drug users. So again, there is some classification of major factor and minor factors. The mechanism of infection, either hematogenous or direct inoculum of bacteria, wound or trauma, adjacent soft tissue and infection. And most infections are monoarticular. 10 to 20% are polyarticular. So this is some like a classification. It's mainly gram-positive infection is likely the source in around like more than 60-70%. Rheumatoid arthritis, they have more of Staphylococcus infection. Gram-negative, we can see it really in immunocompromised patient and in neonate elderly IV drug users. So monoarticular knee most of the time, the infection. And if you have really sarcoiliac joint, you have to think about Brucella and Salmonella. Fever in 57% of patients. So if you have really the sign and symptom of septic arthritis and patient is afebrile, this is only in 57% of patients, they might have fever. So absence of fever does not rule out septic arthritis. This is one of the biggest trial or biggest data collection on the analysis. As we said here before, WBCs, ESR, CRB, non-specific. But if you have more than 100,000, the sensitivity is I'm not really sure about that, but really specific. This is if you have more than 100,000 is really specific. And if from more than 25,000, the sensitivity is around 77%. So if probably you will miss if you stick about 100% or 100,000 WBCs. So 25 can detect only 77%. So you might lose patient if you stick on higher number of WBCs. So Gram stain is a positive in some cases. but sensitivity around 30 to 50%. Synovial fluid is positive in 60% of patients. And the serum procalcitonin diagnostic sensitivity and specificity around 65%. So procalcitonin is really sometimes help, but there is a 35% of patients they might have normal procalcitonin. So a normal procalcitonin, it does not rule out septic arthritis. So there is like a data about the multiplex PCR from the joint. This is data was published last year. It showed sensitivity around 83% and higher specificity in native septic arthritis, but it was really very low performance in early post-operative infection. Probably they assume this is probably as most infection was coagulase negative, so it is not including the coagulase negative. This is one of the multiple PCR that can be used in the joint. The good really thing, it have really a lot of things. One of them is it's Neisseria meningitidis or Neisseria gonorrhea. So sometime if you have really thinking about gonococcal septic arthritis, I don't know if this is really sometimes help, but again, very limited data. We need really more data to have more insight or ideas about septic arthritis. So again, drainage is really important, and antibiotics. If you have to know if your patient is immunocompromised or injectable. So in our patient, he is not immunocompromised. And does the patient have trauma, bacterial arthritis, like surgeries? So no, here in this algorithm, they recommend vancomycin. In our patient, we use vancomycin and ceftriaxone. But if you have really immunocompromised patient, you have to think about gram-negative and Pseudomonas. So again, for how long do we have to treat those patients? There is a Swiss trial was published in 2019, 2 weeks versus 4 weeks of antibiotic therapy after surgical drainage of native joint. They give only 1 to 2 days of IV antibiotics, around 154 patients. And 2 weeks of therapy was non-inferior to 4 weeks of therapy. But this can be interpreted with caution because is around 100%, 100 patient was hand septic arthritis and little knee and hip. So yeah, I think we have really more evidence now. If we have prosthetic joint infection, which I think is more difficult to treat, we use an early switch to IV to oral therapy. So data is really emerging for using of oral antibiotic for such infection. So we go back to our patient. If you still remember him, the WBC was 35,000. MashaAllah, he's living in his farm. And when we went back and asked for a history, a patient, he had a history of Procella 10 years ago. And like daily fresh milk consumptions. And he has a left knee was swollen, infected 10 months ago in his local hospital. And they did only debridement and they sent him home with oral antibiotic, but I'm not really sure what the antibiotic. But when I asked, is this really Procella at that time? He said, no, they didn't tell me that this is a Procella. So Procella IgM was positive and the IgG was negative, and this might really help. I saw like recently data, if the IgG in Procella start to increase after 2 weeks of treatment. So probably here in IgM positive and IgG negative, probably we are in the first week of therapy. Though probably if you go back and ask patient history for duration of symptoms. So Procella was positive from the joint. So this is some word about the diagnosis. I was really late when I had this slide, but I thought there is a presentation about Procella in this meeting. So blood culture is 60 to 80%. Automated system, probably we don't need to cultivate it more than 5 days or as before. Bone marrow is really the more sensitive in chronic form and considered the gold standard. ELISA is both IgM and IgG can be positive. The sensitivity of IgM is 45 to 50%. IgG is 80%. And if we really combine it, it will be like 94%. So very, really unlikely to see. And, we see it sometimes, but in 90% of patients, one of them will be positive. And Procella agglutination in endemic area, 1 to 100, 320, which we don't have it really in our hospital. We have the serology. So the final part is some few words about vertebral osteomyelitis. Again, this is a patient I saw even in my clinic. This is a 34-year-old working as a paramedic and presented with the back pain for 8-month duration, admitted with the left upper limb numbness. Symptoms that start to getting worse in few days prior to the admission. He denied fever. He mentioned there is no fever at all. So there is no night sweat. There is no respiratory symptoms. And we are not really radiologists, but MRI showed perivertebral enhancement, anterior perivertebral areas, epidural infiltrate, worsening spinal canal stenosis. But there is a preserved disc. So in such infection, really sometimes difficult, how to take a sample, what's the differential diagnosis, what's the age of your patients. The top differential usually in our ID clinic is TB, Procella, and bacterial infection like Staph aureus. Malignancies, but he's really young. Bacterial infection like Staph aureus, patient is afebrile, 8 months symptoms. So is this really Procella? Is this really TB? So sometimes we have been asked to start empirical treatment, but really this is difficult. You expose the patient to side effect and with uncertainty of diagnosis. So debridement, biopsy, construction, and fixation was done, and mycobacterial TB PCR turned to be positive. So one of the questions that is difficult in ID part, is this really Procella? Is this really TB? So this is a really nice review from Spain. They are trying to compare TB versus Procella. Sorry. I like this part. In fever, in TB, 1/3 of patients they have a fever. However, in Procella, around 75% of fever. Like in our patient, he's afebrile. There is no fever. And in some reviews of Procella, they are presented with 90% of fever. So fever in Procella is really cardinal manifestation, and we see it like frequently. So our patient is denied any fever. What other else? So posterior vertebral arch involvement is more in TB, but again, this is is very difficult to judge. And vertebral compression and spinal cord compression is more frequently in a TB patient. So even I ask the spine surgeon, can you differentiate? It's difficult. There is no even intraoperative finding unless Dr. Thaqafi or Dr. Arraj or Jamii هنا cheesy material like caseation, but I don't know. So in one French study, around 100 patients with a spine TB, no disc involvement was observed in about half of the cases. So if the disc is not involved, is this really suggestive of TB? But again, there is no really clear or cut-off finding. So this is some recommendation I would like to share it with all of you. And I think this is really important. If you have really positive culture for Procella or Staphylococcus aureus, you don't have to do or to go to imaging guiding aspiration biopsy if you have Procella isolated from the blood or staph aureus. And this is what we use and what we really do in our practice. Unless you have something else, you are thinking really this is not aureus. So what about patient that started treatment and improved? Do we have to really repeat an images? Is the IDSA guidelines, again, they don't really routinely ordering MRI or to do like a follow-up in patient with the vertebral osteomyelitis, giving the patient is improved, and probably the images might like it really is confusing sometimes. The radiological part is lagging behind the clinical part. By this, I think this is the end of my presentation. Thank you so much. يعطيكم العافية.